Welcome, everyone. We're excited to have Dr. Zackary Berger here with us tonight, Associate Professor in the Johns Hopkins Division of General Internal Medicine and core faculty at the Johns Hopkins Berman Institute of Bioethics, to talk about self-advocacy in the doctor's office. So if you have ever wondered how to have a healthy dialogue in the doctor's office, how to prepare for an appointment, how to talk to your doctor in different kinds of appointments, how to advocate for yourself when you don't understand what the doctor is telling you, bring your questions right here. So Zach is going to talk to us, and then we'll have time for Q&A. And folks who are joining us on the live stream will also be keeping an eye out for questions there, so feel free to put them in the chat. Welcome.
Thanks, Erin. Really happy to be here. My second reason for being here is because it's great air conditioning. The first reason is because I really like talking about this topic, and it's really worthwhile to try to get out this information to people that need it. And I want to say at the outset that both here in person and online, I'll be stopping at least a couple times during the talk to get people's questions. So it's not just I talk and then you ask questions. You can ask questions during the talk. I don't see very well, so if anyone has a question during this talk, and you want to interrupt, then perhaps Erin or somebody else can call on people or pick up a question from online. So the talk is called Self-Advocacy and Talking to Medical Professionals, and I should wear my biases on my sleeve, that I think self-advocacy only works if you're advocating for others at the same time. So what I'm going to do, after talking about myself a little bit and what I do and how I came to these interests and these fields and these questions, is I'm going to actually start off broadly. So we're going to talk not just about ourselves and what we need, but what our communities need, what our city needs, what our nation needs, and talk about that a little bit, get your thoughts on what people need, and try to understand how our cities and nations and communities' needs impact on how we are treated and what we can get from our provider visits. Because all these things work together, right? As we've been seeing since January, since whatever historical date you'd like to start with, right? Health and health care is not an individual phenomena. It's a social phenomenon, it's a political phenomenon, it's an economic phenomenon, it's a racial phenomenon, it's a gender phenomenon, it's all these phenomena together. And that means that you're bringing your whole self to the appointment, and your whole self is impacted by the doctor's or the nurse's understanding of who you are and what groups you fit into, but also how the groups you fit into have been impacted by history. So it's a little overwhelming to think this way. I'm not saying you should think this way every time you go to your provider, but it's as if all of history converges on that moment when you're talking to somebody about your health, right? So I'm not saying you need to shoulder the burden of the entire history of humanity every time you walk into the doctor's office. It doesn't hurt, right? And so we're going to start off broadly and cone in. And whenever I say cone in, I remember one of the people that first taught me medicine, Dr. Mac Lipkin from New York University School of Medicine, who always talked about coning in. So you're trying to talk broadly, and then you're trying to cone in on what people need individually. So before we get to the inverted pyramid of this talk, right, talking about social phenomena and then converging on individual phenomena, and then finally how to make the appointment as useful to you as possible based on these things I just mentioned, I want to talk a little bit about myself. I am a primary care doctor. I see adults. I don't see kids. And I treat a number of different kinds of patients. But it's worthwhile, I think, highlighting some kinds of patients that I see pretty often to give you a sense of my understanding of what patients need and what it means to have a useful visit with your provider. So one group of patients I see are people that have survived cancer or are in treatment for cancer, and that's really relevant because people with cancer, obviously it's a very common thing to have, and also it is in microcosm something that everyone goes through, not knowing how to interpret your symptoms, whether the symptom you're feeling is something serious or not so serious, how to not jump at every little thing, but also not how not to overlook things. So that's something that goes for cancer survivors. I also see gender diverse and transgender patients at Johns Hopkins. And obviously, that's a group that's under political repression right now and has been for some time. And it is a group that has to navigate what it means to get medical care. And I'm going to come back to this point later. It's not just about getting to see somebody that knows what's wrong with you and fixing it. It's also having to get certain services that are gate kept. That is to say, there are things that you can only get if a doctor says or a nurse says or a provider says you can get them, right? So gatekeeping goes hand in hand with something called medicalization. When are problems made legible by society or to society? When do people pay attention to stuff? Well, one way that society determines that something is worth paying attention to is when a provider says, oh, this is a medical thing. And this is very much the case for many sorts of patients. I think many people in this room, if not everyone, has encountered gatekeeping and having to get past the gate. But this applies really a lot to gender diverse and transgender people, right? To be told your gender is only visible to us if we pair it with this diagnosis called gender dysphoria. That's definitely a kind of gatekeeping, because not everybody who is transgender feels or interprets their gender in the same way, right? So that's another group of people I see who I think have an experience that is not just unique to them, but recapitulates or reflects in a way a lot of people's different sorts of experience. And then the third group of patients that I think is special that I should mention that I see is undocumented immigrants, who I see at Esperanza Center, which is, as for anyone that doesn't know, a community center on Broadway that is run by Catholic Charities Baltimore. And at my time, is supported there by Catholic Charities and by Hopkins, and for which I'm grateful. And obviously, as we all know, undocumented people, not just undocumented immigrants, but documented immigrants and also citizens, right, are under attack by ICE and federal authorities in various ways. But being undocumented also, I think, reflects the experience of patients in general in certain ways, and that is it's a process of being othered or being outside on the margins, right? Not quite being the proper sort of person who deserves things. And experiencing that categorization of oneself is something that some of us never experience, some of us experience all the time, and some of us sort of catch brief glimpses of in our interaction with the healthcare system. So I think that also provides me a window into what a lot of people are going through. So that's sort of me and what I do. And before, like, as a second part of this preamble, I should also say the last time I was speaking here was actually 2013, and I had just published a book called Talking to Your Doctor. So it's interesting, at least for me, to think about how my view of how best to talk to one's doctor or nurse or provider has changed since that time. And so one, I think, big change that I would notice today is that, again, talking to your doctor is not just an individual phenomenon, but a social phenomenon. That's something I would say. And also, it's to reflect just a bit about social individual relationships. The last time I was at Pratt was I was protesting outside. So it's great to be, several months after I was protesting outside, to be inside. I can say the air conditioning was a lot better inside. So that's very important. So first, we're going to talk about why healthcare is the way it is. Then we're going to talk about and get your thoughts about what you can do about that. And then we'll, as I said, hone in and talk about what it's like to see your provider and how to make that interaction go as well as possible. It's not just about what's going on in that moment. However, and of course, the social phenomena attached to healthcare is not your responsibility or under your control. And that's obviously the frustrating thing about interacting with the healthcare system and seeing a provider, is that so often and we're going to try and talk about how to put things under your control as much as possible. But in the final analysis, the healthcare system is set up in ways that do not listen to patients, and so we have to navigate that, understanding that we might not be successful in counteracting that. So first, in beginning broadly, right, we want to talk about how the political economy of health affects your health and affects your experience in the doctor's office. So political economy is a term that refers to the intersection of politics, how people organize themselves, and the distribution of resources. And this is really important. It's not uniquely in Baltimore, but it's very important to Baltimore, right? Because a lot of our economic engine, the most influential institutions, or among the most influential institutions in the city and in the state, are healthcare institutions, right? And another way of saying this is that, so thinking about what Marx said, I'm mentioning Marx because I'm reading Das Kapital by Karl Marx, and Marx was all about understanding how things gain value. What is it about, like, a thing that you make and then you go and sell that it becomes valuable, right? It's not just about, like, what use you can put to something. It's also about the use that comes to a thing because people spend their time and their sweat to make something into something else, right? So it's that idea of things becoming valuable through labor that also represents the distance between people's work and what they get paid for. And so that's just a long way of saying something that many of us know about life in Baltimore, life in Maryland, life in this country, is that a lot of people in Baltimore take care of other people and don't get paid for it, or they don't get paid sufficiently for it. So in many different ways, right? So that's just even people that don't get employed by the healthcare system might be doing healthcare work on an uncompensated basis. And that's so many people, right? That's like caregivers at home. That's people who have disabled or chronically ill relatives or acutely ill relatives. That's people who that's people who work in different sorts of care settings, right? Whether it's assisted living centers or daycare centers or hospitals or nursing homes, dialysis centers. All those people working at those places are engaged in care for other people, and there is profit made on those relationships. And the people that do that work do not necessarily see that profit. So understanding what money is being made by the system goes some way to understand, to help you understand why your experience in the visit is what it is, right? Why is it that, and I'm not asking for everybody to get sympathy all the time, right? If your doctor's a jerk, your doctor's a jerk, and that's bad, right? And we're going to talk a little bit later about how to navigate that. No one is allowed to be a jerk because the system is bad. However, sometimes it's worthwhile understanding why people are jerks, and why is it that people are overworked, underpaid, and that is because profit is being extracted from them and not being returned to them, and they're being asked to produce more and more with less and less. So that is sort of an obvious truth, but whenever you talk about healthcare in Baltimore, you sort of have to name that because it's often goes unsaid. And so, this is one place where I want to stop and say, first of all, I want to emphasize what we can do, what you guys can do, right? And one thing we can do to make sure that our healthcare interactions go as well as possible is to advocate, self-advocate, and other advocate for equity in the Baltimore system, in Baltimore and Maryland. And maybe, and I'm probably speaking somewhat to the converted in this crowd, right? There are people that are organizing that organizing those that want to found Baltimore on equity, including the With Us, For Us coalition. So if you don't know what that is, I would suggest looking that up, With Us, For Us. And that's a coalition that's looking to have healthcare, the largest organizations in Baltimore, including Hopkins and Maryland, pay their fair share in taxes. So to make sure that people who are doing the healthcare work get compensated appropriately so they could show up for themselves and for those they take care of. So that's, I think, an important thing that you can do to make sure that healthcare interactions go as well as possible. Now what I'm going to talk about is what are barriers to getting healthcare on a community level. So I just talked about how things are set up in a political, economic way in the city and the state and the country, right? As we see Medicaid cuts that will affect hundreds of thousands of Baltimoreans and Marylanders and make care even more difficult to compensate fairly. So that's all true and a definitely important foundation for what we're talking about today. But I also want to talk about community level things that make it difficult to get health care and which will impact any visit you have with a healthcare provider. And after I go through these things, I want to have you express your thoughts on what healthcare challenges your communities have, so we can listen and learn from each other. So in general, it's true, and I think it's a known thing. I don't know if anybody here had difficulty getting a primary care person to see them? Raise your hand if you have difficulty. Right, okay, Aaron, right. And I'm sure there are a number of people online that have had that difficulty. I have one person, well, actually more than one person, several people I know, they're just Facebook friends. They're randomly selected. It's not like I go out and find people to be Facebook friends with that have trouble getting primary care doctors, but over and over again, they're like, does anyone have a primary care person I can see? And it's not comical at all, but it's a tragic skit every time they're looking for somebody because it's so hard, right, in the city and nationally. So the Association of American Medical Colleges projects that by 2034, the country will face a shortage of 17,800 to 48,000 primary care physicians. So a couple things that, and I'm going to talk about this a bit, a couple of things you should always, when you hear a figure like that, you should be a little bit skeptical and trying to ask yourself, who is giving me this number, right? And so you should pay attention. This number came from the Association of American Medical Colleges, and they're saying there's a shortage of primary care physicians. And that's true, but one thing I want to say, and I'll repeat this later a bit, I think, is that for primary care, for getting the care you need, often a nurse practitioner is exactly as good as a physician, right? So you should not, and I think many people have, and as a physician, I appreciate the training I have and my specialist colleagues, and I love the practice of medicine, but I also want to say that in getting primary care, there is a myth that's out there that somehow if you're getting a nurse practitioner, you're getting something lesser. And I think for primary care, that's really not the case. And so that's one way to impact the shortage of primary care physicians and make it so that it's easier to actually get a primary care appointment is by learning or understanding that often nurse practitioners and in certain cases physician assistants can give primary care when an MD is not available, or even when they are available. So one way in which care is hard to get in the community, as I said, is it's hard to get a primary care doctor or any provider that one sees regularly apart from urgent care or emergency care. And then there are other community barriers which we should realize. So one barrier, obviously, to seeing any healthcare professional or to getting to see your provider is transportation, right? So, so there's a very interesting branch of care design that looks at the architecture of healthcare, and one measure of how accessible a healthcare practice is it should be less than a block from multiple public transit destinations, right? It should be accessible in multiple ways. And we know from firsthand experience that although Baltimore has a number of functioning public transportation options, they're not well functioning necessarily all the time, and they're certainly not fully funded. So understanding how to get to the doctor's appointment is a challenge sometimes for people, and making sure that medical practices are actually accessible to people's public transportation. Another barrier that people face to get primary care is time off from work, right? And so one measure of primary care access that people look at is how often or how many practices provide early morning or evening hours or weekend hours. And that is not that common, right? So, so I'm not just talking about community needs, but obviously characteristics that you can look for as you try to find useful practices. And then obviously locations of practices, making sure they're accessible, not just for transportation, but things that make sense for you or your difference from your workplace or your childcare needs. So before I'm going to segue a bit to asking you guys here and the people online what our community health needs are, what our chief community health care needs are, so we can understand how that factors into our use of our doctor's visits. But before I do that, I want to say, just like I said, made a point about saying what you could do to address the political economy of health on a national basis. I also want to say that you can do something about these primary care barriers as a citizen, as an engaged Baltimorean or Marylander. And again, this group is probably enriched in people that have done this already or know about this already, but I'll say that anyway. And that is that there is a group, Baltimore Transit Equity, that is advocating for a Baltimore Regional Transportation Authority. And they're looking to collect letters from people to their city council people to advocate for this Regional Transportation Authority, which would help centralize funds and plan for Baltimore transportation on the part of Baltimoreans, not on the part of Maryland state government. So if you go to moretransit-equity.com, you can figure out or learn how to send a letter to your city council person to try to bring down these barriers to getting care. So before I move to talk about techniques and things that you need to look for in your medical visit, I want to open up for just a bit and ask people, what do you think your neighborhood or your community healthcare needs are? What would you name as the most important health needs? Either here or online. I'll, uh-huh. Right. So yes, transportation is definitely important for getting access to healthcare. But I guess I was trying to even apart from needs in accessing healthcare, what do you think the community's health need is? Like, what are the community's top health needs? If you were to think about what people are suffering from, what you know your neighbors are going through. Sure. Yeah, that's a great example, right? So I think mental health is a huge unmet need for many people. I know in Baltimore and certainly in Maryland and nationally as well. And I think briefly there's a lot that goes into that, and that's something that goes into our visits with our individual providers. Obviously, the need for mental health services went up during the COVID pandemic, which we're still living through in certain ways. And primary care mental health providers have seen their reimbursements cut. And so it's been difficult to keep a steady supply of mental health providers who are actually around taking patients. So that's definitely a community need that really impacts how people can get care. If you can't get your mental health appointment, it's difficult to address those issues. Other needs that people think exist? Yes. Mm-hmm. Yeah, I think that's a great point. I think that also goes to um, trying to support local media and local sources of information that are reliable, right? So you need more than just aggregators. You need more than just AI to summarize things. You need to have a human being to put things in context and relate it to your own individual or communal needs, and that's really important. And part of what makes it challenging, and we're going to get into this a little bit more soon, what makes it challenging to interact with healthcare is that you're not, and this is an obvious truth, but I'm going to say it anyway, is that you're dealing with specialized knowledge, right? That's why we can't, much as I would sometimes like to do this, you can't only depend on mutual aid. Mutual aid is really important, and I think in certain ways it can supplement and substitute for certain kinds of primary care, right? If you have a well-organized society and people need food and they know what food banks to get to, what community pantries to get to, that's really important. Or if you need housing, you know where to get housing, right? Or if you need safety from violence, you know where to get that. That's really important too. But there's certain sorts of specialized medical knowledge that actually can be effective. So the problem is trying to understand how to access that specialist knowledge and when you need to get that knowledge, and you can't rely on general care, right? And so that requires a certain level of knowledge and certain level of information. So I think that kind of reliable information is lacking for a lot of people, right? So I think that's a really good point. So I was going to, unless anyone had anything more to say about community health, is one thing that really comes to mind when I think of the community health need, and I guess this is because I see so much of this in my practices, is the care of diabetes. And because a lot of places in Baltimore are lacking healthy, regular food access. But not only that, there's a lot of lack of access to medications. And so the armamentarium that physicians use or providers use to access diabetes care is really limited. So, so being able to get good diabetes care really, the things that are lacking to the community really impact on the individual visit. I'm just going to drink water 1 second, sorry. So now I want to segue to, the topic of the talk as understood in a basic level, right? Not a basic, but an individual level. So we've talked about population needs, state and national needs, health and political economy, and what the community is going through, right? And now I want to talk about what you're looking for, right? When you see a provider. And I'm going to come at this with my bias, right? I'm a primary care provider, and our ideal approach is soup to nuts, right? Ideally, if you're an adult and you walk into our office, we can take care of pretty much anything from a health perspective. So that's different from if you go to a specialist office and you're seeking a particular kind of specialist care. But when I'm talking about is often how best to get primary care. So one thing I said just now, but I'm going to repeat it, right, is that I think often these days, you know, MD and nurse practitioner care is equivalent, and a lot of the providers that are taking new patients in the area and are able to be accessed are nurse practitioners, and I really value collaborating with them. One thing that is very interesting is that doctors, physicians as a guild, are trying to protect their scope of care and are actually advocating against nurse practitioner practice. Not so much in Maryland. I think in Maryland there's less of that gatekeeping, but in other states that's something that's still very much a live practice, which I think is really inimical to trying to provide people access to care. And so, you know, I think, and a lot of these truths I'm going to be sharing are not incredibly novel, but they're worth saying because I think in large part some of them are true. So reputation matters, right, in seeing a healthcare provider. Credentials do matter, right, and accomplishments matter, but I think reputation among people does matter. I think sometimes people like to act like or would love it if there was some sort of more objective measure of quality of healthcare than reputation. I think in certain specialties that is probably true, right? If you're seeing a surgeon for a given procedure or operation, what the literature tends to show is that if your surgeon does more of a given sort of thing, you want, and that's the surgeon you're looking for. If you have a gallbladder issue, you don't want to see a surgeon that does all sorts of different stuff. You want to see a surgeon that does gallbladders day in and day out, right? But for primary care, I think it's a different sort of thing. And it really does matter what sort of reputation somebody has. Sometimes it can be useful, as we all know, I think, to look at the websites for the given hospital or network or whatever of which the provider you're looking for is a part, and those give ratings, right? And those ratings are, you know, definitely gameable, definitely selectable by the employer, but I think maybe give some indication of differences among people, but also personal networks matter. And I think it's also important to be skeptical about providers, right? There are, you know, there are bad doctors and nurses out there. I think it's useful to check two sources I'm going to name now. One is the Maryland Board of Physicians website. You can search the Maryland Board of Physicians website for complaints and legal actions taken against physicians. I think that's important to know about. The website ProPublica, which is a really important source of public-facing, public service journalism these days, also has databases with which one can search for actions taken, legal actions taken against physicians and other providers. So I think it's important to be forewarned and forearmed and look for problems that people might have had. It's really important, you know, this talk is in English, except for the ASL interpretation, which I really much appreciate. And besides English and ASL, people speak different languages, right? If not you, then other people you know. And I think it's really important to actually get some concrete answers to the question, like, will your practice speak my language? Because while there are federal requirements that any practice that gets Medicare funding provide language concordant care for people, that is, if care that is in the language of someone's preference, often that's more honored in the breach, that is to say, not honored. And that's for many different reasons. I think it's because, one reason it's because in-person interpreters cost money. It's because if you don't understand that people speak other languages, it's kind of hard to get in that mindset, and it takes time to get interpreters, and as I mentioned at the beginning of this talk, healthcare providers, like everybody else, are squeezed to do more with less, so people are incentivized to assume that everybody speaks English. So I really think it's important to ask if you have any language needs, or your loved one does, to really be specific about it. Are you going to use an interpreter? Have there been any issues, right? And I think the other important thing I want to mention is that half of seeing a doctor, roughly, or a nurse or provider, is having them help you figure out what's wrong with you and fixing it. That's sort of half of it. And the other half is paperwork, right? And so we know that the reason people have to see a doctor or a nurse or provider often is not just to help get fixed what's wrong with them, but to deal with the gatekeeping that I mentioned at the beginning of this talk. Whether that's disability forms, whether that's Federal Medical Leave Act forms, whether that's, for example, if you're in a position where you're really having housing insecurity and you're worried about electricity turned off or being evicted, and you need a letter to testify against that. If you're gender diverse and you're looking for a letter to gatekeep, to testify to the properness of your gender identity, right? All this stuff requires your provider to sit down and take what is often uncompensated time to fill out that paperwork. So you need to hear from the practice or from whoever you're talking to what the time delay is on that, how those things are asked for, right? Who are you going to be hearing from? That's something that's important, right? And then before I get to the last point I'm going to talk to in talking about what practice characteristics you'd like to ask about is what kind of visits they offer. And I think everybody knows that since COVID, it's been a lot more common for practices to offer televisits, and that could be very useful. However, often televisits are done through various video platforms that are kind of technically daunting for ordinary computer users. I'm just speaking about this from my point of view as a primary care person who has many patients that theoretically they get a link to a video visit, but you can't actually click on the link, you can't actually open the link. So you need to figure out whether the practice you're going to interact with can offer an ordinary phone call as a visit. And you'll be surprised that some practices don't, right? Because that's involves different sorts of reimbursement. And so some practices are really incentivized to push people towards video visits, which can be great. Don't get me wrong. I did several video visits today. They were useful. So that's sort of practice characteristics. And obviously I'm going to take questions. We're going to discuss things about all the stuff I've mentioned today. But I'm now going to move to the last sort of bit I'm going to talk about, and that's maybe what you might have expected I talk about first, which is how best to navigate the visit. One big thing, I love all my patients. All my patients are wonderful, right? But I love my patients even more when they bring a list. And this is very funny because I'm not a list maker as an individual, but as a physician, I really love it when a patient brings a list to me. And oftentimes, and you could tell you can tell how this reflects the inborn prejudices we have about how patients are supposed to sit down and shut up, right? Often I get patients that are apologizing to me for bringing lists, right? Oh, I'm sorry, is it okay if I have a list of things? I'm like, are you crazy? I mean, I love lists. Please bring out your little notebook with your list all the time, right? One thing that all providers should learn in NP school and in nursing school and medical school and whatever is how to, and this is something you should be, I think, you or your loved ones should be prepared to do in the doctor's office and whoever's office, is agenda setting, right? I mean, I think this is a great facility to have. It's a great practice to get into in meetings across the board, right? And that agenda setting is just the the way of negotiating your needs and the provider's needs, right? The provider has their needs. As we've discussed, they are being incentivized to provide certain services that make their institution money, right? Some of them might be helpful to you, some of them not so much, but you're not going to change everything in this visit that you're going for. So you're going to have to negotiate what the provider wants to get done in the visit versus what you want to get done. And so you're going to have to meet in the middle, right? And so if your provider is a good communicator, which I'm not saying happens all the time, they'll be thinking about how best to negotiate that. And you also, I think, should be thinking how best to negotiate that as well. And that's why making a list is so important. Ideally, a ranked list. What's most important to you, right? What's least important to you? And you might not get to everything. And we all know everyone's time is limited. Healthcare visits most of all. Transportation stinks, so you might be late, right? You might have a crisis at home or whatever it is, right? So you might be even later. The doctor themselves can run late, right? So, you might think of what point you have to get through at the doctor's office no matter what, and you might think of more stuff if you have time, right? So that's making a list is wonderful. Often, I think we've all had this experience, when you go see your provider, it's like being a deer in the headlights, right? Because many healthcare environments are not comforting and are not patient-centered, and it's not expected that people actually ask questions, and bringing a list is not met with enthusiasm. And so that's why it's really important to have that third party. Again, difficult sometimes. People aren't always waiting around to accompany you to medical appointments. They have their own things. But if possible, having a third party, a friend, a relative, a loved one, who can be there to be your eyes and ears, to be your brain when your brain turns off, I think is a very salutary thing. I would recommend that for every visit. And it doesn't need to be someone there in person, right? It could be on the phone. And I think, everything I'm saying here, if any provider finds them outside the bounds of what they prefer, that's sort of a red flag, right? Like, if any provider doesn't want a third party there, or they don't want things recorded, or they don't want a list, and they want to drive the visit, it's not a huge red flag, but it's a moderate-sized red flag, right? Unless they have good reason for it. So that's something else I would say. Bring a third party. Bring your medications to every visit, right? You've heard people say this, I think, but if you're taking medications, bring them. What's the next best thing to having a third party, as I've already said, right? Taking notes, recording a visit, all these things are really important. Our system is conditioned against asking for second opinions. I think many of our healthcare networks like to see themselves as a walled garden, right? That we're providing everything and we don't want you to go to that other place. But we also know that not everybody thinks the same way, and it's important to get second opinions. And then before I stop my prepared remarks and ask people for questions, I want to emphasize this quality that I think is really important, and I think gets short shrift, because I'm encouraging people when they go to their provider to be skeptical. And I think that sometimes gets lumped in with not appreciating the necessity of specialized medical care or believing in wacky stuff. But I think it's important to be skeptical because medicine is not based on some received truth, right? Medicine is done by human beings. There's no pure science about medicine. not every medicine, when a doctor suggests a treatment, it's not because they know exactly what's going to do the right thing for you. It's because they're making a judgment like a human being, like we make judgments. And so doctors can be wrong. Medications can work just as well or poorly as placebo. Things change. And I always, it's a cliche, but some cliches are true. So when somebody knows their own body, I think that's worth listening to and worth recognizing. And it's worth recognizing as an individual too, as somebody that goes to see a doctor, that we know our own bodies and we should be skeptical of things that don't seem right to us. Broadly speaking, this, to have that confidence and in our own knowledge requires that we have some sort of healthy orientation to the world. So, sometimes we can be so stressed or sick or deficient in what we need that we're not able to have that skepticism. So I'm not saying that works all the time, but excuse me. Being able to recognize that what doesn't seem right to you might not be right to you, I think is really important. So I want to stop here, and hopefully there'll be questions about things I've said, things you might not agree with, or experiences you've had that you wanted to ask about, whether in person or online. Here? Yes. So, right. So if you're looking for a second opinion, for example, you're thinking about a specialist question, right? So you have a thing going on with your intestines, right? And your digestion is not working right. And the GI doctor that somebody referred you to is saying this thing, and you're not quite sure you want to go through a colonoscopy. Maybe you could take a medicine instead, right? And so in that case, if you're looking for a second opinion, depending on the network you're in, your primary care person might be able to put in a referral and ask if you could speak to somebody else. That could be a possibility. So sometimes, yes, you're able to get a second opinion, a referral through your own primary care person's network. Oftentimes, unfortunately, it's going to be on you. And that is, it's a lot of effort. But I think sometimes, that is the way to do it. But yeah, there are certain circumstances where, especially if it's a specialist question, where the person you're seeing, if they're giving you a referral to a specialist, should at least be thinking about whether they can give you a referral to another specialist in the same area. Questions?
I'll just kind of hop in on that question that was just asked. But how do you go about discern whether or not you should seek out a referral, especially when, like we were talking about earlier, like systemic issues that people face, whether it be with inaccessibility, like transportation. I mean, in America, especially with like the costs of medical assistance as well. Like, how do you go about that if you are, let's say, a difficult situation, but are discerning about whether or not you want to seek a second opinion on something?
So your question is how do you know whether seeing a specialist, getting a specialist referral is the right thing? Is that the
Yes.
question? Yeah. That is a great question. I think, again, this is coming from my bias, right? But I think being able to get a sense whether the thing that's going on with you is more or less a common thing that your provider has seen and can help with versus something that requires a different level of care, right? I think that would be the first question. And so I think a good primary care person should be able to distinguish what things need specialist care. That being said, that line is going to be different, slightly different for each person, right? There are things I'll just give you an example, right? That I have had insurance companies tell me that if I'm prescribing a medication for someone's gender affirming care, that's not coverable because I'm not a specialist. Well, I'm an internal medicine specialist, but that's true. I don't have a credential in gender affirming care, but you don't really need one. It's not like I'm not doing a complicated surgery. I'm just giving medications and talking about risks and benefits like all other medications. So I think some providers will have a different line when they think something as a specialist needs specialist care and when something doesn't. But I think that would be my first address, right? Is finding that primary care or longitudinal care, someone you can see over time, and that goes back to the difficulties of getting primary care. But that would be my first answer.
Kind of the question that we were talking about earlier, that if how to sort of talk with your doctor when a particular treatment or medication or something is being recommended, but you have a past sort of negative experience with that, sort of how to have that negotiation.
Yeah, and I think it's a great question. And I think trying to be transparent. And I also like, if someone is giving, I think you told me about this experience before, where someone is saying, oh, this person should use a topical cream or something, and this person is not going to use a cream. They're just not going to do it. So I think being able to give reasons for that experience is helpful, at least to the person on the other end. This person, they're not going to remember to use this topical treatment, this cream or whatever. They're not going to remember to take their medications. I'll give you an example. I have a number of patients that they're working construction jobs, and so they're leaving their home at 5 a.m. and they're going to somewhere, right, hours away, and they're not necessarily able to. They don't have access to a cooler or whatever. They're not necessarily able to bring their lunch, right? So if you tell them to eat a healthy lunch, maybe they're not going to be able to, right? So I think just being able to give some advice, as a patient, to give your experience with reasons is really helpful to the person on the other end. And then to be transparent about it and to say, this is my experience. I can't promise that the person on the other end will listen to you, right? We'll assume that all providers are listeners, not all providers are listeners, but at least being able to give reasons and be transparent about it should go some way toward being helpful.
Questions?
Got an online question here. How does one deal with moving to a new provider after having multiple negative experiences with others?
Right. How do you move to a new provider after having multiple negative experiences with others? I think, so there's one sort of patient that I've had a lot of experience with, which I think a lot of other doctors have experience with too. And it's a person that, and I don't know if this person has had this experience, but it's somebody with a lot of chronic conditions and symptoms that have not been well treated by previous providers. And people come with a lot of materials of their experiences, lists and binders. And a lot of providers, understandably, have this feeling of heart sink when they see all these materials. But for me, although I do feel the challenge of the moment, it's good to get all that material to understand the history that someone has gone through. So if the negative experience with previous providers has been because this person has had chronic conditions that haven't been well treated, to be able to tell that story and to be able to construct a narrative to present yourself in a legible way to provider, I think is really helpful. To be able to say, this is my story. I've had patients give me, handouts with a narrative about what they've been through, and that, for me, that's very helpful. So that's one way of thinking about it. If the experience has been like the providers haven't been able to fix what's wrong, and so you're documenting it, maybe the next provider will be able to listen or be able to fix things in a way the previous haven't. I can't promise that. There's another sense in which it might be that you're just coming up against systemic failings in these previous providers, right? Maybe you've met a bunch of people that don't listen to Black women, right? And unfortunately, that is the case for a lot of people, right? This is not a new systemic thing that I'm discovering, right? So sometimes, again, I've had people tell me, my doctor didn't listen to me because I was X. What do you think about that? And I try to talk about my experiences and how I try to listen, and sometimes that's helpful. Then there's a whole bunch of big practical, like ball of wax about how you transfer stuff from one provider to another provider, and where one office might not be inclined to give your records to another person, so that's a whole different thing. I'm not sure if that's also underlying the question too. And then I guess the last way I would answer this question is, it's really easy to have shitty experiences in the healthcare system over and over again. I think a lot of people do, right? So I don't want people to feel like, oh, if only I just make lists and behave well and construct my narrative appropriately and bring all the information and the doctor's going to listen to me. No, I think it's a lot of people have bad experiences over and over and over again, and that can lead to if you're burned once, what's the phrase? Burn once, twice shy, whatever it is. So people feel like I don't want to go to another doctor and have them or another provider and have them not listen to me, and I can't blame a person for that. And that may be, if you need specialist care, then you're going to have to get that specialist care. You can't cook up chemotherapy or insulin on your own, right? But there are certain kinds of care that can be available in non-medical settings that might be helpful, right? So if you have sometimes mental health issues, right, then sometimes pharmaceuticals are not the best way to go about it, right? Or chronic pain, right? There are various ways in which various kinds of healing arts can be just as good as medical professionals. So yeah, there's a lot that can underlie that question, right? It's a great question. I think a lot of people have these experiences of hitting a wall over and over and over again, right? Actually, my final answer to that question, I've had a lot of experiences like this, or people that have had experiences like this. There are people that think that their chronic symptoms are explicable by some diagnosis that hasn't been found yet. Sometimes that's the case, but sometimes it's not. And there are a lot of people that, to be honest, waste a lot of time and money trying to chase after a diagnosis to explain everything that's going on. Sometimes that just doesn't exist. So I don't know if that's, I'm not saying that's underlying this question, but sometimes that does happen where you have people that go to a zillion doctors and I think part of that is because of the medicalization I was talking about earlier. People feel like they have to have a doctor stamp what's wrong with them and validate it, and if they don't get the diagnosis, their feelings are not validated. But if people can have lots of chronic symptoms without having a medical explanation, right? Plenty of chronic pain doesn't have a single explanation. So if you're going to a zillion doctors and you're asking for the diagnosis that will fix everything, maybe you're not going to get it, which, it's not good to hear, but sometimes that's the way it is. Thanks. Thank you so much for your time. And do remember to advocate for self and for others, right? I think maybe that's my takeaway, right? Advocating for others is a kind of self-advocacy, and that will hopefully improve things, especially now. We need that now. So thank you very much.
Thank you so much for being here tonight. Really appreciate this insight and ideas. And folks, if you think of more questions in the next few minutes, we're here. Thank you again. Thank you all for coming. Thank you to our two ASL interpreters.